which we are extremely excited to bring to you on the role of AI in suicide prevention, risks, benefits, and practical next steps. So, just by way of brief introduction, beyond the general hype around artificial intelligence, in many ways, the characteristics of AI and other digital interventions are perfectly suited to address a lot of the long-standing challenges in suicide prevention. So, for instance, although, as we just heard about, suicide is a leading cause of death in the US and South Korea, around the world, it's a low base rate problem. And so we need data on really large samples to be better able to predict it and prevent it, and digital approaches can help solve that. Also, we know from work around the world that only about 40% of people with suicidal thoughts are able to access treatment. Online and phone-based approaches can really help address that as well. And intervening with those at risk requires great care and conversational sophistication. And with the past few years, we've seen great evolution in large language models and other forms of AI that many think have really helped address this problem as well. So computers, artificial agents are getting much better at simulating what human clinicians are able to do. And just this past July, the US government issued an executive order and an AI action plan aimed at really speeding up AI development in the US. So this is a wave that is not going away and is only getting bigger. At the same time, though, um, there are many very public instances of these technologies going wrong. And in some cases, people have argued that these technologies have contributed to the problem of suicide, such as by failing to act in the face of clear risk, or in some extreme cases, actually encouraging people at risk to kill themselves. So, what's the truth about the current state of affairs? What are the things we should be most concerned about regarding these technologies? What are the greatest opportunities and paths forward? So, we're really delighted that some of the world's leading experts in this space have agreed to join us today for a panel discussion on this topic. So, I'll briefly introduce the speakers and then start off our panel discussion, and then we'll open it up to you all who are joining us here today to ask whatever questions you have. So, please do stay tuned and post any questions you have to the Q&A, and we'll get to them, hopefully as many of them as we can. So let me first introduce our speakers and welcome each of them. I could take about 15 or so minutes to introduce each of them, given their incredibly impressive credentials, but I will give a very scaled down introduction so we save time to actually hear from them. So first, I'm delighted to introduce Dr. Rebecca Brendel. Dr. Brendel is an MD JD, so double doctorate, and is the director of the Center for Bioethics at Harvard Medical School, and at MGH is the director of law and ethics at the Center for Law, Brain, and Behavior. She's a practicing psychiatrist, forensic psychiatrist, and a member of the Massachusetts Bar. So she brings great expertise both in mental health and in the law. She's past president of the American Psychiatric Association, the Academy of Consultation Liaison Psychiatry, and is currently a consultant to the World Psychiatric Association Ethics Committee and the American Medical Association Council on Ethical and Judicial Affairs. So suffice to say, her incredibly broad and deep experience gives her great expertise on all issues related to the interface of psychiatry, medicine, law, ethics, and human rights. And we're delighted that she's joined us here today. Also joining us is Dr. Tanzeem Choudhury, who's a professor at the Cornell Institute at Cornell Tech in Information Sciences and co-founder of Health Rhythms Incorporated. As part of her doctoral work at MIT, she conducted the first ever experiment that uses mobile sensors to model social networks, which has led to a whole new field of research referred to as reality mining. And she's been doing cutting edge work leading our field ever since then. At Cornell Tech, Dr. Choudhury directs the People Aware Computing Group, which works on developing machine learning techniques for systems that can reason about human activities, interactions, and social networks in everyday environments. So she also brings tremendous expertise to this area, and we're delighted that she's joining us today. Also joining us is Dr. Jeremy Davis, who's an assistant professor in normative and applied ethics in the Department of Philosophy at the University of Georgia. He is also an ethics specialist at Compass Ethics, an ethics consulting firm, and sits on the board of directors of the nonprofit Georgians for End-of-Life Options. He received his PhD from the University of Toronto, and his research interests focus on questions surrounding the ethics of killing and harming and the ethical issues raised by novel technologies. So perfectly well suited for this discussion. And his most recent research is focused on ethical questions arising from the use of algorithmic systems in the police and military contexts. Thank you so much, Dr. Davis, for joining us. And last but not least, I'm delighted that Dr. Rob Morris is joining us. He's a co-founder and CEO of Coco, KOKO. It is not a chocolate company, but instead a tech nonprofit for mental health, a phenomenal company and group that addresses the youth mental health crisis by meeting young people where they are online and providing free AI-based digital interventions. Coco has reached over 4 million young people and has worked directly with most of the major platforms in the field: Pinterest, TikTok, Tumblr, OpenAI, Twitch, and others. And Dr. Morris's interests lie at the intersection of AI, social computing, and digital interventions for mental health. Rob, thank you as well for joining us. So thanks to all of our panelists. I'm so excited you're here. This is a panel discussion we've wanted to have for a few years now, but we couldn't quite get the right people here, and we have them today. So thank you so much for joining. I'd like to start us out by asking each of you, if you could, to talk a little bit about what you see as the greatest opportunities and risks of AI for suicide prevention. And for this one, perhaps we can start with Rob and Tanzeem, more on the sort of tech creation side, and then go to Jeremy and Rebecca on more of the ethics side of things. So, Rob, do you want to kick us off, please?
Sure. And thank you, Matt. It's great to be here. So when we think about AI and mental health and suicide prevention, one thing that always comes to mind for me is that to make a real impact, a population level impact, we have to reach people where they are. I focus on a youth demographic and where are young people? They're on TikTok, they're on Snapchat, they're on Instagram, they're increasingly now on LLMs, they're on companion AIs, they're using ChatGPT for homework. I think this is true for the global population and adult population as well. And, whether we want this to be the case or not, these platforms often act as first responders. They're where people are immediately reaching out for help. That presents risks and opportunities. I think for the opportunity, if we can design these systems to mitigate risk and also get people to the right help at the right time, we can have a tremendous impact. So this is where people's eyeballs are. How can we use that opportunity to get them help that is evidence-based, that goes beyond good intention and actually has measurable data behind it? If we can do that, we can have a profound impact in mental health. So I see that as a big opportunity. Risks, I'm sure everyone here can point to a lot of them. Sometimes it's just easier to think about risks than opportunities. I will focus on one in particular when people ask me this, what keeps me up at night mostly in this whole space is AI companion companies
Mhm.
and products, especially for young people. I think when we look at large internet and technology companies, really focusing on the business model tells us a lot about the potential risks and how the story might unfold over time. And I'm especially worried about how sophisticated these LLMs are getting in terms of persuasion and the ability to keep people on the screen. And if there are business models where engagement is what is monetized, and they're building companion AIs. There are a lot of really scary dark patterns here where people will become, attached to these agents. Maybe those companies will not have the best interests in mind for the users, and it can set up a very scary and dangerous scenario. So I'm worried about that in particular, but of course there are a lot of other risks I'm sure other panelists will raise as well.
Great. Thanks, Rob, for raising those big points. And I love the way that you frame that. What are the opportunities and what are the things that keep you up at night? So, Tanzeem, what are your greatest what are you most excited about and what are you most fearful about?
I think from my perspective, like technology and digital tools and AI has been used with the promise of improving people's overall well-being for decades now, right? And I kind of bucket it into three categories, right? Access, cost, and quality, right? And I think and they have to kind of work together. I think their biggest kind of opportunities are in increasing access and lowering costs, right? So as Rob mentioned, that there is a huge amount of reach that these tools have, and people are using it. And just like the smartphone, right? It's everywhere, and there is kind of it's an opportunity to leverage that to get to where we want. And so many people, particularly in mental health, and besides, like, don't have the access and cannot afford the level of care that is beneficial for them. So I think we should leverage that access and the affordability of it. But I think quality is where things vary a lot, right? But I want to kind of echo kind of Rob that there is so much signal in these interactions about the user that can be used to help, right? So we have seen through kind of our digital traces and digital patterns, people call it digital breadcrumbs, right? You have huge amount of information, and particularly in behavioral health, that is very informative, right? And but over the decades, we have not used it effectively in clinical care. And I think one of the risks comes in, there is kind of the danger of it, but I think both the technology and clinical kind of communities have to work towards what is the right way of incorporating this information, rather than saying there isn't enough evidence, it can be harmful, and actually shutting the door. Because then what happens is these technology evolves anyway and people use it anyway, and then the clinical side gets left out of the picture in some ways, of like being very not in times with what the users want, and particularly with young population, right? So I think one of the things with the youth, I would say, there is so much, and I think we've made that mistake repeatedly, right? We say screen time is bad. It's not universally bad. We say social media is bad. It's not universally bad. And now if we say like LLMs for mental health is bad and we should ban it, people will find ways around it. So I think it's so important from the get-go to find ways to make it kind of keep pace with the innovation and put the right kind of safety guardrails to make it less risky, but not kind of just say we need to kind of stall the use of that. So I think that's, to me, is kind of one of the greatest risks.
Great. Thank you so much. Some great themes, some overlapping, some unique. One that I definitely want to come back to is this idea of sort of, Rob mentioned business model. Tanzeem, you alluded to the fact that, I will rephrase, the toothpaste has left the tube. This is happening. People are using these tools. They're going to develop them. They're going to use them whether we like it or not. There's going to be some misalignment of our goals as academics, as health professionals, as industry partners. How do we sync up and do this in a way that's responsible, and best for the user? So definitely themes we'll come back to. Jeremy.
Yeah, thanks. So I'll echo a lot of what Rob and Tanzeem have already said, and I agree that one of the greatest opportunities here is access, particularly to people who otherwise wouldn't have access to it. I think this also is going to be the case with most of these. There's a kind of dark side to that too, which creates one of the risks. I will note too, one of the other major opportunities or benefits here is, unlike we might expect in ordinary clinical contexts, the opportunity is there, whether or not it would be successful, but there's certainly a theoretical opportunity that these kinds of systems could get better over time through machine learning technologies, so that we could imagine the clinical or the kind of quasi-clinical responses would get better and better. I think that also, again, creates some downsides that we should be aware of. But one of the risks I wanted to highlight that hasn't been brought up yet is how this might affect things at the level of the system, beyond just the level of the particular interaction with a given individual. For example, I could understand the worry someone might have that this, who works in the mental health space, who might think that this increasing use of, say, ChatGPT or other LLMs for this, for mental health, that this might create a lack of desire, perceived lack of need to actually visit in-person clinical mental health professionals. And that might over time at the level of the system, create incentives for, say, insurance companies to not offer, coverage for mental health care until or unless other, chatbot style things have been tried first. And maybe that's good. It seems to me to be a risk in particular because I think ultimately, at least as things are now, the clinical context is the one we would most of us, I suspect, would prefer people had access to. Kind of in a related vein, I think there's a question here about whether this, though it is good, it does seem to address a problem with access to mental health. It's not obvious to me that if we had some amount of money to spend or invest, that this would be the way to do that. And instead, maybe thinking about opportunities for increasing access to mental health that does not involve kind of putting it into a second best space, like dealing with chatbots and that sort of thing. So it seems to me that on the one hand, a lot of the opportunities actually have a component of a downside right there, right next to them. So I think thinking about which of those is most likely and what we can do to mitigate the effects of that is probably the central, most important task.
Great. Thanks, Jeremy. And I was grabbed by your comment about second best, and that's another point I want to return to is sort of how good is the technology right now, and is it, some evidence suggesting it's as good as humans in some ways. Might it be better? Might it be worse? So definitely something I'd love to return. Thanks so much for those comments. Really provocative. And finally, Dr. Brendel.
Thanks. And well, I had ideas about what I wanted to say until I heard what my co-panelists had to say. And now I have so many ideas
Great.
circulating. So this is great. One of the things that I want to highlight here, just to bring into the conversation, maybe, is that there's no question we have opportunity. We do. And, sort of be channeling Jim's words earlier about our moral responsibility to be optimistic. The problem with suicide is one that's been really vexing for us as a society in general, with multiple typologies, multiple cultural senses, and understandings of suicide. We saw that too in the preceding session. And then I think the challenge and the opportunity more broadly goes along with that, that really when we think about suicide in that broad frame, a lot of it has to do with mental illness, but it's not just mental illness alone. So when we're talking broadly about suicide prevention, we're really talking about a collective action problem of society, right? Or human problem. But when we talk about the act in the particular, we're talking about an individual problem, right? So I think both the promise and the risk of using AI is that we can learn a lot more about the societal problems, about social determinants, about different understandings and conceptions of suicidal behaviors and suicide. And yet also we can learn more on the opposite extreme about individuals' mental health and their propensity for suicide, and how we bridge between those two, and how we're clear about the research that we do and the responsibilities we have at the macro level and the individual patient level, I think are things we have to be really clear about. Just to echo what some of the other panelists have already said, when we think about the use of AI in the clinical realm, what are we comparing it to, right? We already know that we have a huge need for mental health care. Matt, where you and I are both in the Boston area, one of the most overrepresented population-wise places in the world in terms of mental health clinicians and researchers. And yet we know that the hardest call we get every day is to find a clinical referral for somebody, right? Because it's so hard to find that care. So I think the promise is both understanding typologies on the one hand and being able to respond to them. And that's also the promise, both on a societal level and on an individual level. And I'll stop there.
Great. Thanks so much for those incredible comments. And Rebecca, you mentioned riffing on what people are saying. to the panel, feel free to jump in. I will do my best to moderate, but if you have questions for each other or want to build on things that others have said, please go ahead and do so. So I want to get a little more specific, and ask for whether there are any exemplars in the suicide field or more broadly, other areas of medicine, other areas of Rebecca law, where this is done really well, where AI is used for mental health or for health more general. You don't have to, I'm not going to ask you to name names or name companies in one direction or the other, but I'm curious about examples of components, programs, interventions that you've seen work really well that we should build on, or the opposite, things that don't work really well, or things that are harmful, clearly, that we should try and avoid. And while you ponder that for a second, I want to just say, as a suicide researcher and who's been trying to do this work for decades, um, it's really exciting to have technology that can reach a person when they're in a suicidal crisis. Because as a clinician, I'm a licensed clinician as well, this has been missing for forever. And suicidal patients, people struggling with suicidal thoughts in the moment, have been a little bit of a hot potato. This is something that Rob and I have talked about for a couple of years over time. When a patient's at risk for suicide, they tell their clinician, and the clinician says, well, here's some things to do when you leave the office. Call a hotline. And you call a hotline, they say, well, use your safety plan. And the safety plan says, call the hotline. So no one quite knows what to do in the moments when a person is at high risk. And with digital interventions, with AI, we now can be in the moment, in the room with the person. But the big question is, what do we do? What's helpful? What's harmful? What now back to my question, what do we think works? What do we think is harmful? Are there concrete examples we should keep in mind and build on or avoid? This is all skate. Anyone interested can jump on in, as they used to say at the skating rink in New Jersey where I grew up.
I can jump in to preserve the order of panelists. I feel that's my implicit responsibility. In terms of like examples of things being done well, I think I'll focus on my area in particular, which is how are large internet platforms and technology companies responding to at-risk individuals on their platform? And it really varies. We work with all sorts of different companies, and it's often very surprising to me and would probably be surprising to the audience to learn which companies think very thoughtfully about this and which do not at all. I will say the companies that are doing the best work are those who are focusing really, really carefully on risk mitigation, but also acknowledging the potential for impact. And then the second, you know, approach is moving beyond good intentions and intuition and actually going towards evidence-based principles. I think that in general is a really interesting area, and I'd love to see more platforms and more companies in this space looking at actual evidence and doing research. You know, we can have all sorts of really well-informed and good intentions around, let's make sure these LLMs are telling people repeatedly they're not a therapist or they're not a human. That's an empirical question. We don't know how that could change behavior or not. So organizations that are actually looking at those as empirical questions and doing the data, I think is a really good step forward, in particular.
I can also chime in. So I think kind of echoing on Rob's point about kind of being thoughtful, I think like I also see that there is kind of two aspects. One is, you know, this is an area where the technology is evolving rapidly and solutions need to be kind of keeping pace. And also there is kind of the technology itself needs to evolve, right? So I think there's two ways of kind of thinking about it. One is, and the kind of whether you kind of shift the burden to someone else, like someone's parents or caregiver, and say, here are tracking tools, and you kind of figure it out, versus actually kind of improving the system, right? So we have recently seen things around broadly around like red teaming, how do you find flaws and how do you address it? But even this concept, and very recently around like, oh, there is this AI vaccine, right? You intentionally inject information and evolve the model to kind of deal with it. So I think there is technology that improvements that can be done and should be done thoughtfully. And the other thing I think is there is so much evidence-based results, but they're not often done in a technology context, right? In a clinical context. And I think we are not doing enough to say, how do we kind of blend the best of both worlds, right? Evidence-based results cannot just be copied into a digital platform. And I think that often, if you think about like suffers engagement and people don't use it, right? If you just have a digital therapeutic solutions or things that is just a digitization of a paper or in-person implementation, it just doesn't translate. So I think we need to do more work on saying what's the blend, and the blend is going to be, I think, very important going forward.
I think there's also this piece about being clear what spaces and kinds of interventions we're talking about, right? So are we engaging in a space that's meant to be clinical, or is presently clinical, or needs to be clinical, or rather is social? And how we develop our tools, how we develop our interventions will depend in large part around how we conceptualize what the purpose of those tools are, right? So on balance, it's better to have young people will say lots of things online that they would never say to me in my office, and to each other. So, there's a lot of work going on about how to create networks and communities where people can avoid the kinds of loneliness or isolation and find social support that's critically important. And yet, on the other hand, when we are thinking about tools that come into a clinical space, as clinicians, we have really clear responsibilities about what we're supposed to do. And most of us are ill-equipped to understand how that interacts with an AI tool of any kind, right? So understanding, of course, that we could go anywhere from, that not all AI tools, interventions, and developments are the same and are actually quite different. So I think clarity around who's responsible, what the purpose is, and where it belongs is going to be really, really important to figure out how to do this well. And it will also help define and redefine what the role of the human in the loop is, so to speak. Is there a human in the loop? And if so, what is that all about, and what ought it to be about, so that we can fulfill our various responsibilities?
Actually, I wanted to pick up on that, Rebecca. I agree completely, and I think the point about responsibility, particularly as it pertains to the question that Matthew had asked about which companies are doing better or worse at this, and this goes back to a point Rob made too about sort of thinking and taking on the responsibility seriously. There's a phrase that I think originated in the context of thinking about autonomous weapons systems. You'll forgive the clumsy analogy, but this idea of a responsibility gap. So the idea that sometimes when these autonomous systems are sort of sent out into the world, they do things that their programmers, often which involves, dozens, hundreds of people maybe, or even the person who sort of pushed start and started the particular system. It does things that we either wouldn't have expected, or we couldn't really understand how the programmers or any given programmer could be held responsible for that. And so there's this gap. There's a harm that's done, but there's nobody we can really point to and say, you're the one responsible for this, or this team is responsible for this. And I think that, I'm inspired to see that there are organizations and companies that are accepting the responsibility and saying this system that we are implementing, like we take responsibility for that. But all too often, I think people are very ready to not take responsibility, or to use that sort of responsibility gap to say, we didn't know it could do this. We don't take responsibility for that. That's not really, our fault. So I think seeing that there are organizations that are accepting that they have responsibility for that is good, and I think that will be crucial to mitigating some of the most deleterious effects of these kinds of systems. Just seeing people step up and step in and take that responsibility seriously.
Thanks, each of you, for that. One common theme that's emerging is one of the questions that I had, so I'll jump into it now, is what is, each of the past two speakers mentioned this, what is the role of humans in the loop? And we had a question come in the Q&A that I'll paraphrase to say, one of the things that concerns, the poster said, concerns me about these approaches is when there's limited or no supervision. Is there a qualified person who's in the loop, especially when these are life and death decisions? So to play sort of devil's advocate, many people will say, well, there should always be a human involved. If a person's at risk for suicide, the gold standard should be a human licensed clinician interacting with that person. The devil's advocate parts comes in to say, but most people don't have access to care. There's not enough trained licensed clinicians who are trained in evidence-based interventions to be there with the person. And in many cases, the person doesn't want a human with them at their side in the moment. So how do we achieve this balance? What are the things we should be thinking about? Is there an ideal set of principles or guidelines for humans in the loop that we should use, that industry should use, that researchers should use? I don't know if we'll all agree on this, but I'm curious to hear your thoughts.
Well, let me go in reverse order and take that first from the beginning, because I think that we love the concept of human in the loop because it makes us feel better. It's not really clear that a human in the loop actually makes things better, right? So I just want to point out that we are notoriously bad as humans at assessing risk, especially in times of uncertainty. And we do know that we are incredibly well intentioned, and I back myself up for the many times I've done this as a clinician over the past 25 years, that we overprotect people when we know the risks are great. And that's not a bad thing, but it doesn't help us advance the kinds of learning and interventions that we really hope for when we think about what AI could do for us in predicting and preventing something that ultimately is a low base rate phenomenon. And so I think understanding the meaning, and maybe I'm teeing up Jeremy here, but understanding the sort of the meaning for us of what that human in the loop is all about on a human level, and also on a theoretical level, right, a conceptual level, is really important, because then we can figure out who's better at this particular thing. If it's about churning lots of kinds of data and finding a common point, that's not going to be the human in the loop. And if it's about really trying to look broadly at new features or common features across thousands, if not millions of possibilities, that's not going to be the human in the loop. What's going to be the human in the loop is a well-trained person or accompaniment, or for now at least an intervener on some level. But I think the concept itself is something that we really have to break down if we want to build our best tools and our best interventions on behalf of those who are really, as we've said, struggling to find good mental health care.
Yeah, I would agree with all that. I think the question of the role of the human in the loop, as Rebecca said, is sort of often used to sort of make us feel better. And I do wonder, like, if there are opportunities for this, let's just say with like a ChatGPT system. I mean, what does that actually look like in practice? Does it mean that anytime somebody uses certain keywords, there's some kind of somebody that's brought in to monitor that chat? My suspicion is that in many of the cases that we're most worried about, the average user will find ways to circumvent this. And maybe Rob, you have some thoughts about this with Coco. I mean, you kind of have to. It's sort of a whack-a-mole situation in that, the way people talk about these things or are likely to talk about them, particularly in online spaces, is constantly changing. And so you'd have to sort of be, as a programmer, you'd have to be ready to identify those earlier than they're actually used. And my suspicion is that in many cases, individuals are just going to find opportunities to talk to ChatGPT or whatever the way that so they can get the results that they need. And sometimes I think that would involve circumventing this process, even if it were in its ideal form. So I guess I'm not super optimistic that this is a realistic approach, but I do like the idea in theory of saying, there's some safeguard. But again, I also share the worry that Rebecca raised, that it's not obvious that in many cases the human in the loop will do better. And in many cases, I think actually would probably do worse. Not necessarily because it's a human, but because that kind of friction in the system might cause people to just not take advantage of the things that actually are helpful for them in the first place.
Yeah, I think these are all really interesting, excellent points, and maybe I'll echo, your devil's advocate position a little bit there, Matt. I think for most people, what they fundamentally want is to get well. They don't necessarily know or want a human all the time. Like the final outcome is perhaps what matters most. And I think I see this a lot in debates, not just about where a human can exist in the loop of these systems, but in general, these kind of simplistic dichotomous press headlines of should there be an AI therapist or not. And the therapist community will say, well, AI, doesn't understand empathy or compassion. And there are many paths to wellness. Good sleep, good diet, um, exercise, social community. It's not clear to me there's a singular preciousness that we need to adhere to all the time. And yet at the same time, echoing Jeremy, your point a while ago, when there's very little friction to use AI systems for the user, it's right there. It's maybe more comfortable, it's more anonymous, and maybe even for the whole system, for health companies, et cetera, it's cheaper. We run this risk of losing the in-person clinical context and the resources behind that. So that is indeed a worry I have as well.
Just quickly kind of following up. So I think like if we think about human in the loop, like a colleague of mine at Weill Cornell Medicine kind of it's like who is a practicing clinician said that I hate the concept of human in the loop. It's just like the tech companies trying to offload liability to me, right? So I think like just what is the use for the human in the loop is an important kind of consideration. And how I think on a lot of these discussion, what's the structure, right? So I kind of think about that we don't have enough human resources. So how do we structure AI or these tools to be part of the care team, right? And I know in mental health we have the collaborative care model that was evolved to provide that support. Like, what does it look like in overall mental health or in suicide prevention? What's the structure of a clinical team where AI is part of that team? I think that definition needs to be there. And then the other aspect is timing, right? Sometimes AI alone is enough, and sometimes it's not. So I don't think there is a fixed notion of human in the loop. Sometimes human in the loop is essential, and sometimes it's
Mm.
not. And I think, again, like this whole like binary categorization, I don't think for anyone, human in the loop is a constant need. When someone in the moment, someone in the middle of the night or whatever, right? There are times and timing between appointments, right? That AI can provide the support. Right now, there is that's non-existent or hard to get to. So I'd say those are important things to think about.
Yeah, the question about human in the loop has come up several times in the Q&A, and we're just past 11 o'clock Eastern time, so we've got about 17 minutes left in this session only. Time is flying when you're having fun. So if people in the audience have questions, please continue to post them in the Q&A, and I'll try and pepper them in as I can. So several people commented on, Alan Sheik had a few good questions. Other anonymous poster as well about what is the potential role of human in the loop. Is it, machine generates potential crisis responses and a human sorts them? Someone else mentioned a safety feature where if an AI or LLM detects risk, should it ping like a safety contact? Should it ping a human? Um, Several times people mentioned evidence base and the need to iterate and to experiment. One really wonderful example I always come back to is the Samaritan's Radar app. And I mentioned this not to call out Samaritans, but well, to call them out to say what a great job they did here. They created a really well-intentioned app that ran on Twitter, and it found people at risk, and it reached out to people in their network. And they only ran it for 7 days, and it seemed to have negative impacts. It would reach out to people, reach out to the bully in your network, and they would bully you even more, as one made up example. So they pulled it down. So well-intentioned things can go awry, and so we've got to experiment. And we probably have to experiment with human in the loop. Maybe in that instance, having a human in the loop would be helpful. Maybe it would be harmful. But I think the importance of experimentation is perhaps a way to try and figure out what are the right ways and the right places to have humans in the loop. I don't know if anybody wants to respond to that or add to that.
Well, where we do have evidence and we know how we do things, it's important to heed that evidence. I guess one of the things that worries me is that a human in the loop would just be using a machine to assist the way we've always done things, which is generally imperfect, and not really expanding our minds to think about the ways that we could actually do things different, right? So that we could pave new pathways and new dimensions of how to respond to suicidality. I don't want that to be taken to mean, though, that as a psychiatrist, I think that we don't have a role in taking care of patients, and really a very high level of responsibility for doing good and preventing harm, right? Twin principles of beneficence and non-maleficence. I do think we at least have to use the human in the loop concept to question whether we're really harnessing the power of technological innovation, if what makes us feel safe, even though we know there's evidence and we ought to follow it, prevents us from doing things in different ways that actually could have even greater benefit.
Great, thanks for that. Related question from Rafaela Galdeano in the chat. As AI becomes more integrated into suicide prevention efforts, how should medical education and ongoing professional development evolve to help clinicians both interpret AI outputs and to ensure that their clinical wisdom, to paraphrase, is retained? How can we best do this? And do you know of existing efforts to do this?
I think I'll just chime in. Like, this is an active discussion that we are having, and and I think universities are the place to do kind of think about across the aisle, right? Like, I think it has to be done partnership with the technologists and the clinical kind of side of what does medical education in now look like in with the age of AI and with the age of technology. I don't think there is an answer yet, but like I think there are, but I think kind of my conversations of current generations of clinicians that I work with, they are thinking about it, right? And how do we kind of have more opportunities of doing kind of education that interweaves both sides. So I think one of the things, like, technologies have their own curriculum path, and then you have medical education. There is so little room to do anything else. Like, how do you kind of incorporate kind of technology requirement and pieces into existing medical kind of structures? So I think one of the things we have kind of seen is there's so much pressure on their schedule and time frame. There is no opportunities to actually kind of inject and intersect. So I think you need to really rethink the curriculum, right? Because it has to be a priority of how do you kind of blend. And I think it's also for the technologies, which we are doing. Like, we have a program in health tech. The solutions that students come up with without any clinical input or understanding, not just on the clinical research side, but clinical implementation side. What does it take for an algorithm to be deployed in clinical care? The solutions are like not great, right? So I think that interweaving, like, we operate in our own kind of disciplinary silos still when it comes to education, and I think that just doesn't scale in this kind of era of where technology is making such a huge role in healthcare. So I think how do we go beyond disciplinary boundaries is key.
Great. Another topic that has several questions asked in the chat is whether the panel can talk a little bit about bias in current AI mental health and outreach models if you see it. Um, Knowing what we know about the general lack of diversity in tech and coding. And there's a related question about digital equity and the digital divide. Advances in AI integration to prevent suicide seem disproportionately accessible in English-speaking and high-income countries. So how do we address these? How do we best address these issues or address them at all?
I'll chime in with what I hope is an optimistic take. I think historically, when designing algorithms for crisis detection, English is the first language that is studied, deployed, evaluated. But increasingly, I'm seeing more and more opportunities to scale these to other languages and other regions way more quickly. The advances in machine translation have just been phenomenal in the past few years to the point where we no longer have to have reams and reams of carefully curated and fine-tuned training data that translators have labored over for a long time. We need some of that for certain types of gold standard data, but increasingly I'm seeing like some really exciting ways in our work and others to scale these to other languages. That said, I think one thing I'd love to see more is voices that are typically not heard in these conversations. I think that may be the heart of this question. In the world I work in, youth and parents and ethnic minorities, they need to be the ones advising these companies as well. And often their voices get drowned out by louder ones that are more typically brought to the table on these things.
I think the aspect of lived experience is so important, right? And the other thing, particularly with youth, and I see that schools and education kind of systems, like they are often not the first to adopt technology where the population there are. So there is a big divide in educators and administrations in schools, like particularly pre-college, and those who are kind of evolving in this kind of teenage years. And I think that's also another important area of bringing how do we actually kind of think about that from a much earlier kind of stage in terms of education.
Great, thanks.
I'll just sort of jump in on the equity question because it's a really important one. We know in the history of progress that every major technological innovation has widened the divide in health equity rather than ameliorated it. And so, we just heard some pretty compelling examples from Jim on this earlier, and from Peter. And I think, what we need to be on the other hand, sort of interventions in making mental health care accessible on a population level has far outpaced in low and middle income countries, has far outpaced what we've been able to do in certainly in the US, but in general in high income countries. So I think that there's really in the lived experience and the listening part here, there's also this way in which if we want to get this right, it can't start from the top down, but it has to start from the community level also and branch out to see how some of these really successful innovations at the community level could be even more amplified through the use of technology and not just think about framing in a model that we find ourselves in.
Yeah, you've presciently addressed a few of the questions in the Q&A about how should we train clinicians, therapists to teach patients about safely using AI for treatment. If I can reinterpret what you said or paraphrase, we can do that, but that's going to miss a lot of people who aren't connected to care at all. There's already this big divide. How do we reach people directly? So there's another question about the need to engage people with lived experience and figure out how are they using chatbots and other kinds of interventions so we can talk directly to the people most likely to be using these technologies. We did a qualitative study, if I can steal a minute here, a qualitative study where we interviewed adolescents coming to the hospital for suicide risk. And we asked them about how they used social media. And they told us the ways that it was helpful and ways that it was harmful and so on. And what was one thing that was really striking is the sort of clinicians in the room had no idea how kids were using social media. And it wasn't part of the treatment plan. It wasn't part of the assessment at all. It was a huge part of the kids' lives, but not at all baked into what clinicians were doing. And these approaches now have the ability to reach adolescents where they are. So it's a new privilege that we have, but we've got to, I think, to paraphrase a lot of what you've all said, got to figure out how best to use this newfound power that we have responsibly. We only have about 5 minutes left. I'm wondering if you can each share what advice you have for scientists, students, industry professionals, family members, those who may be listening, advice for what those of us who are pursuing science and clinical work, what we should be focused on, how we should use the technologies, what questions we should ask, or for those on the lived experience side or the family side, what should they be looking for, thinking about moving toward to be educated consumers of some of the tools that are coming out.
Yeah, one thing that I would encourage anybody who's thinking about this from whatever perspective, even if you're just a casual observer, is, often when we talk about these things, we're speaking counterfactually. We're saying if we had done this differently, or if they were banned, here's what would happen, or if they had greater access, here's what would happen. And I guess I want to encourage people, if you're going to think counterfactually, think counterfactually. Like, think about all the different possibilities and the different ways this could go, not just at the, right before the problem arises. And so again, just to go back to something I had said earlier about kind of thinking about this at the level of the system, this is the toothpaste is out of the tube, as was said, but it's also worth asking, like, are there like better alternatives that have nothing to do with this? And again, thinking about increasing access to clinical contexts would be ideal and great. And of course, it's not as if that's just we can just shift money over to that or something like that, but really thinking more broadly and really thinking about it, the reason we're thinking that these might be so useful to people presumes and holds fixed the lack of access. And that's a human problem that we can work to solve. And so I think, if we hold a lot of things fixed, then I think we get a lot of answers that look really favorable to using these systems. But also, I think we should be prepared to go further back in our analysis and ask bigger questions about how things might be different. And so again, like, I think if we're going to think about alternatives and counterfactuals, we should be open to the full slate of those, not just the ones that are closest to the very specific problem that we spot.
Great. Thank you so much.
I'll jump in. I think a big core message for me is really trying to move beyond good intentions and leveraging evidence-based and data and treating some of these questions as empirical questions and studying them and trying to understand what is working and what isn't working. And then I'll poach a few points made by panelists. I think, Rebecca, your point around that I was hearing around automation is really interesting. I think all too often when we have a really exciting new technology, our first pass is to automate what humans are already doing when there's a huge opportunity to go beyond that and think about innovation. And if we really focus on the core outcomes we care about, which is helping people get well, helping prevent suicide, versus automating, lockstep what people are already doing today, we will miss out on an opportunity. I'll also echo, Tanzeem, your point about design in the loop is so important. If we have papers and clinical recommendations, and then we have technology, and we're not looking at this fundamental human-computer interaction component that speaks to whether people actually use things, people will not get served. So we really have to think about that as well.
I can go kind of next. I think I would say in terms of with the current kind of scientists, researchers, and students in industry is that I think we need to be involved in the bigger kind of conversations around policy, education, as well as research. And I think kind of we need to kind of shape the process and own it more than we do beyond kind of writing papers. And because I think that if we look at, and I was intrigued by like there was recent kind of findings around like half-life of medical knowledge, right? It was like 50 years in the 50s, and now it's like 2.5 months. That was from 2020, right? It's going to go fast. So what does it mean, evidence-based approach? Like we have to really rethink how we generate evidence-based approach, because the way we are going, the speed matters. And we've seen in terms of regulatory processes, other things, it's not keeping up. So then things that are non-evidence-based are getting scale and access. So I think, how do we rethink about what does it mean to, in this era of rapid medical knowledge generation, to think about evidence-based approaches is really important.
I know we're really short on time, but let just end on a note of optimism, because I think some of what drives us to technological innovation and solutions in mental health is the lack of access. And I would say, if we were going to leave with one big point, it's that we should think expansively about how we can use technology to advance our care and to advance mental health more broadly, and really, really push ourselves to think differently, to think smarter, and to think innovatively about the possible.
Great. Thank you so much for that, and for ending on a note of optimism. And thanks again to all of our speakers here today. Really, really appreciate your being here today, and even bigger, the amazing work you're doing to help us understand all of this and move the field forward in a positive way. So thanks so much for joining us.